Welcome to episode 205, Assessing and Addressing Intimate Partner Violence Legally and Ethically, featuring Dr. Keith Klostermann, licensed marriage and family therapist and mental health counselor. Make sure to subscribe to be alerted about future episodes by Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and today I am looking forward to a conversation with Dr. Keith Klostermann. He is a licensed marriage and family therapist and also mental health counselor. And his specialization is understanding violence within couples and families, how there can be some impact by things like substance use disorders or other conditions. I'm grateful to Dr. Klostermann for joining us today because I know for me, speaking as someone who's not specialized in couples therapy, a conversation about violence in couples and families kind of makes my skin crawl. And I am grateful to clinicians like Keith who have this specialization that can help increase our awareness about this phenomenon and then when and how do we work with it. Thank you so much for joining us, Keith. I appreciate you coming on.
Thanks, Beth. I'm really delighted to be here and excited for the conversation.
So please take a moment and tell us how you got into this particular specialization over the course of your career. Your bio is so impressive, from teaching to all these different specializations. How did that bring you to where you are now?
Oh, thanks. So interestingly, I consider myself a clinician at heart, but when I graduated, I spent 10 years working on federally funded clinical trials, specifically related to couples therapy for substance use disorders. And in the process of doing that, what we found was that a large number of men in particular were perpetrating violence toward their female partners in the year before entering treatment. So it's like, even though we were looking at improving the relationship in terms of relationship satisfaction and happiness, what we found was that these men that were being admitted had been violent in the year prior and oftentimes it wasn't caught at intake. We were catching it because we were doing a research protocol. That's why we knew. But the clinic's sort of standard operating procedure didn't catch it. So for me, it was sort of like looking at it and saying, look, there's this whole population of people that are at risk that are going totally unnoticed. And then when you extrapolate out further and you think about kids in the home and the impact that has on the system, it's sort of like, hey, I think we really need to look at this. Think about what we're doing and how we might do things different.
Thank you. Thank you for coming on, like I said, to talk about this because it gives many of us the heebie-jeebies. And before you and I started recording, we were talking about how this is so easy to miss. It was only through the research that you were doing that you started noticing these patterns. But I'm picturing myself being in an assessment and you ask this question or maybe two questions and then you move on and then that piece of paper disappears into a filing cabinet or you put it in your electronic health record. And then we don't think of it as like an ongoing changing process. So I'm looking forward to the information you're going to give us today, which I imagine is going to correct some myths that we have as counselors talking about intimate partner violence.
Well, I think that's such a great point. Typically, the screening process with couples isn't very thorough. And in fact, it may only screen one of the partners, right? So if it's the partner that's actually perpetrating the violence, she or he may say, well, no, nothing's going on, right? So we don't know, right? And if it's only one question, which oftentimes it is, depending on the setting, do we really get an accurate assessment of what's going on with this particular couple? The data say that the violence is occurring. The challenge is we're not catching it.
There's so much to cover during the hour that I have you. Why don't we start by first you defining what constitutes violence? So, when we talk about IPV, intimate partner violence, can you break down the different kinds of violence just so that we can kind of adjust our eyes to that light of what we're looking for?
Sure. Yes, that's a great question. I think, we often think of physical violence. There's sexual violence, emotional violence, verbal abuse, financial, right? All of these things that are used to control another person's behavior, to bend somebody to their will. In the work that I focused on with addictions, we looked at the physical side of things, but we know that these things don't happen in isolation and that oftentimes it's a whole sort of toxic stew of physical, emotional, financial, that's being used to control somebody's behavior.
And when looking at specifically physical violence, can you describe the different kinds, that situational kind of episodic versus the more chronic nature of ongoing violence? I think that, I know for me, is one of the places where the line becomes muddy. It's hard for me to see this category from that category. Can you describe kind of the classification of different types of violence that are occurring in their frequency?
Yes, thank you. Thank you for this question. So I think a lot of times what happens is we think of violence as a homogeneous phenomenon. It's just one side. It's just violence and that's it. But as you said, Beth, I think there's different types of violence. I like to think of it on a continuum, where on the one end we have what you said, which was, these sort of instances that arise out of increased emotion. There's no fear of partner. It's an isolated instance of a push or a shove. Tends to be bi-directional in nature, but it's not frequent. It's not ongoing. On the other end of that continuum, we have the more serious and scary type. That's the violence that's being used as a form of power and control. There's fear of partner. The violence is severe. It's frequently ends in broken bones, hospitalizations, and so on. So in those, depending on the type of violence that you're dealing with, that has implications for treatment and what you would consider doing or not. I want to be super clear, if there's no other takeaway from this. In those instances where there's severe violence, should never, ever, ever do couples or family treatment. Never. It's always contraindicated. Okay. So that's a deal breaker. Because we never, above all, safety first. Don't want to put anyone at risk. In situations where it is an isolated instance, right, of a push or a shove, there's no fear, it's bidirectional, couples therapy can be a useful modality. And in fact, the data support that. If you look at some of Sandy Stitt's work, the couples therapy is actually more effective than individual-based treatment in treating those forms of non-severe violence. So I think it's not just an academic exercise. It has implications for what we do in terms of treatment. So it's really important to think about, well, what am I dealing with, to know that? Because again, you never want to end up in a situation where you've got somebody that you're sitting with that's been extremely violent. I think you have to be aware of that. Pretending it isn't there is not a good answer.
When we're looking at these more isolated incidents, what does it take for situational violence to potentially go into the scary, chronic, coercive kind of violence?
So I think this is your question's a good one, and it speaks to the importance and the need to routinely screen, right? We need to know on an ongoing basis whether or not the violence is occurring. So when I mentioned earlier, part of, if you will, the definition of non-severe would be it's infrequent, right? It's not continual. If we notice that the violence is more frequent and it's happening once a week, and we're also noticing that it's escalating, that would be a red flag, right? It also speaks to the importance of knowing that screening routinely and screening separately, that's the key. Right? So that, let's say, Beth, your example is a good one. We get a couple in and they report initially, right, prior to the first meeting, that it seems like it was an isolated instance of a push or a shove. They seem like appropriate candidates. But then we're 2 or 3 sessions in and we notice this pattern. If we're routinely screening, we can have a conversation, especially separately, right? To say, hey, what's going on? I'm noticing this is still happening. What are your thoughts about this? It gives us a chance to come up with a plan for how to address it. Is it even safe to address it in the session, or do we need to start thinking about alternatives? So the question's a good one, right? When does it turn into something other than that? And I think that's where you have to monitor. You don't want to find out after the fact, hopefully, because you didn't catch it, that this is going on.
There's so much here to discuss. So when thinking about this non-severe category of intimate partner violence, that is responsive to treatment. It's not contraindicated for us to do couples therapy. So you have a session where you meet alone with one of the partners and they say, yes, I have engaged in violence against my partner, and you meet with the other partner, and she says, yes, I actually, sometimes when I've gotten really mad, I've pushed them across the room. How do you talk about that elephant in the room when you know that as a clinician? Like when this finally comes out, which maybe it's in the first session, but at least it's been my experience with families in particular, when there have been incidents of violence, there's often so much fear about those things coming out. Are you going to call Department of Child and Family Services? Are my children going to be removed from the home? Are you going to arrest me? Like, what's going to happen? What is your role in this system that's going to make me pay for what I've done? So how do you do that?
Well, yes, very delicately. But having said that, transparently, right? I think being clear about what my role is and also the limits of confidentiality and what we talk about is really helpful, because I think it helps partners to understand, here's where, this is my role, this is what I can do. I also think helping them understand that the way they've been doing things up to this point hasn't worked, right? And they've come to couples therapy because they want something different. And usually, in my experience, by the time we get to couples therapy, and especially and we're talking about the non-severe instance now, people recognize, look, I probably shouldn't have done that. They may say, yeah, you know what, I drank too much, right? And it got out of hand. I can't believe I did it. I'm embarrassed. I hate myself for it. Whatever the language is, but there's recognition that this got way out of hand. We can't do that. So I think we have to address the elephant in the room, and it's symptomatic of other issues that are going on, right? And we have to understand that, and we have to be able to talk. We have to be able to have honest conversations. Typically, when people come into couples therapy, by the time they come in, they've gone underground with sort of what's really going on, right? So they don't talk about it. And what happens is it builds up, and then by the time they get in to therapy, there's a lot of resentment, right, for things that have gone unsaid. A lot of filters there. So part of this is unpacking that and helping the clients, each partner, to sort of speak what it is that's going on. Because if we don't do that, then all we're doing is just going through the motions. So we have to be able to have those conversations and to acknowledge it is painful, right? And it is hard to talk about these things, but it's necessary if things are going to change.
When thinking about non-severe violence within a couple or family, one thing that occurs to me is a potential referral for something like anger management. For someone like you who is so well versed in these patterns, when do you decide, like, this is when we need to add this additional resource, anger management or individual counseling, or I think it's depression that's causing a rage? Like, how do you decide when it's like, okay, it's okay for me to work with this couple and keep this as couples counseling? And then when you go, okay, here are all these other professionals that I want to get involved in the treatment.
Yes. I think that, that's always an ongoing discussion. And it really is a discussion. Me sharing, this is what I think here's how I think you might benefit, right? And maybe focusing on this piece will allow us to focus on the relationship, right? Because that's really what we're talking about with the couples work. If the couples work turns into focusing on one partner's, let's say, central issue, whatever it may be, well, then it's taking away from the power of what we have in front of us, which is each person's in the room, and we really want to focus on their relationship. So sometimes saying, maybe you would also benefit from thinking about trying this. It's not unusual. When I was doing couples therapy for substance use disorders, we'd often find the goal was to strengthen the relationship and use the enhanced or strengthened relationship in the client's recovery, right, to support it. For a lot of partners, they had been through so much, it was important for them that they would tell their story, right? And it was always the same story, and it was valuable, but we could spend every session every week just talking about all the terrible things that had happened. In those situations, would often say, you might benefit from having some other support, right, to sort of work through this, which would allow us to focus more on the relational aspect.
Going back to even defining different types of violence, can you speak about some of the types of intimate partner violence that we as clinicians might be missing? So I imagine if someone gets pushed into a wall, we go, okay, that's IPV. But what are the other things that may be occurring that we may be misclassifying as nonviolent, but really are foundational to our understanding of IPV and what's happening in the system?
I think the emotional abuse piece often goes overlooked. It's seen as a symptom of the relationship. Oftentimes the consequences of it are far more severe. And so I think we don't do a good job of assessing that. I think even the financial piece, the financial control, that even when we become aware of it, I think a lot of clinicians don't know what to do with it. So I think that when it's overt and it's physical, it's easier to detect, and it's also easier to address. When we see some of these other forms, the emotional, even the verbal, there may be a reluctance to address that within the session. I think those are the pieces that often go unaddressed. There's another important point that I think is worth mentioning, and that's in a lot of, at least in my experience, anecdotally, a lot of couples that come in, they were raised in families that maybe, let's say, weren't the healthiest. Maybe the parents didn't have good communication skills. Maybe the parents didn't have good conflict resolution skills. Sort of what they learned. And then so they grew up, they got into relationships, and then the relationship went south. And they don't have that sort of reservoir of, hey, I can draw on this. This is what I could do. They just, and truthfully, they just don't know because they never learned it. And a lot of couples work oftentimes is sort of teaching couples how to effectively communicate, right? How to resolve conflict in healthy ways, because they just never were exposed to that. So I think that I say that in the context of I have a real sort of respect for that piece. Oftentimes, I don't think it's that people are trying to be nasty, aggressive, whatever. Sometimes it's just what they know. And I think creating awareness of that, how it came to that, from family of origin type stuff. And then also, how do we do it different, right? When people come in, they always want something different, or they wouldn't be there. Who goes to see a therapist just because, right? So I think that's part of it. Helping create awareness that the current ways of doing things don't work. And then also, what are their individual goals and what are their goals for the relationship? To that end, what I'll say is, I think it's all of us have our own goals and what we want. And sometimes, my old mentor, Tim O'Farrell, Tim developed behavioral couples therapy for substance use. Tim used to say, sometimes we can help couples break up without breaking out. And what he meant by that was a successful outcome wasn't always that they stayed together. Sometimes in the process of doing the couples work, it becomes apparent that this isn't going to work. And maybe we can have conversations that are better for both partners. And then if there's kids in the home, even them. So
when you have a couple that is in the scary category, and that becomes known to us, whether through individual assessment or, it may be obvious in the way that they're presenting and one partner isn't given the opportunity to speak, things like that. What is the right response for, other than saying like, I can't do this right now. But when you're in that category, particularly if you're the partner that's experiencing the abuse, that's being abused, goodness knows you feel like you don't have any remedy. You feel like you don't have options. And so then you go see a couples therapist and they say, yeah, I can't work with you. And you go, well, now what?
That's right. Well, yes. And I think this is a real concern. I mentioned to you earlier, Beth, I've had partners that have come to me in which we did a baseline assessment and they were ineligible. They were excluded based on the level of violence. And the partners would come to me and say, look, I totally get it, but I want help. Like, I'm willing to take the chance. I want to do the couples work because I'm staying and I want things to get a little bit better. Right. So it's like, well, what do you do in those situations? I think, the issue is tricky. And what I mean by that is if you become aware that there's severe violence going on while you're doing the couples work, I think you have to have a conversation. You have to split the partners up, have a conversation, especially with whoever, the non-aggressor is, to say, look, what's going on? What do you need? How can I help you? Here's some supports. Also, to come up with a plan to make sure that that person's going to be safe. Like you said, Beth, you can't just pull the plug and say, oh, we're not doing this anymore. because that can have implications for the partner when the partner goes home and the other partner says, "What did you say?" Right? So we have to be really mindful and aware. A lot of times the way that it's been done is we couch it as, look, it seems like we're not making a lot of progress. I want to get this is what I think. I want to get your sense of it. Here's what I think. Right. And at this point, I think each of you would benefit from going on and doing your own individual work. And when your individual work is done, maybe we could come back together as a couple. Right. But it's a way to sort of split them apart and to stop the couples work, but also to provide resources and supports for the partner. Yes, we can split them up and recommend individual treatment, and we can do it cleverly and come up with a way that works. If we don't give the partner support, though, then all we've done is kick the can down the road, right? That's the situation you're talking about where the partner says, well, that's great. So now what? Now what am I supposed to do? So I think that's where we have to figure out and again, I think this is a collaborative conversation, right? And probably an ongoing one. What does the partner want? What are the partner's options? What does the partner view as his or her options? How can we help them with that? If it can't happen right away, what are the supports that we can put in place to make sure the person's safe, but in addition to also make sure that there's a plan, right? So, and I think having an action plan of what to do in the event that things get scary is really, really important. Sort of break glass in case of emergency. So these are all the types of conversations that you would want to have to make sure someone was safe.
You had mentioned the prevalence of bidirectionality in the more situational intimate partner violence.
Correct.
When we're in the severe category, does it often happen bidirectionally, or is it very often a clear pattern of abuse from one party to another?
Yes, great question. And I'm so glad you brought this up. With the situational violence, it tends to be bidirectional. With the intimate terrorism, the more severe part, it is predominantly male perpetrated. So it's not bidirectional. It's male to female violence. So, and sometimes, there's debate oftentimes in the field about the idea of bidirectional violence and is it true, is it not true? I think it depends on the type of violence that you're assessing. If we're talking about non-severe violence, that's where we see that it tends to be bidirectional in nature. But the severe type, make no mistake, is predominantly male perpetrated and far more serious and aggressive.
Along those same lines, looking at this through a lens outside of a hetero relationship, can you speak to patterns within other types of relationships, whether that's two men that are together, perhaps it's poly? Like, what happens with IPV when we're not looking at the Times New Roman font of a straight couple?
Yeah, this is an important question. The research evidence in this area is really underdeveloped, although there has been more research lately, and the results seem to indicate that the types of violence and the characteristics are akin to what we would find with hetero couples. So there seems to be similarities in terms of that. That's not to say that it is identical, but I think that a lot of the things that we're talking about now could be applied to other groups.
When thinking of the statistic that you had shared about most often, if we're looking at severe intimate partner violence, it's usually from a male to a female partner.
Yes.
Does that mean that if we're looking male to male partnership versus female to female partnership, are there higher rates of violence in male only relationships? Do you know?
I don't know that. That's a good question.
Research area.
I'm not sure.
Yeah, thank you.
Yeah, for sure. Well, but again, I think that's part of, the challenge, and there's a few challenges with doing research on partner violence. And this is part of the reason why the literature tends to be underdeveloped. It's, it's really, really sensitive, and getting people to participate and to cooperate is challenging. Trying to get it through a human subjects review board, right, to sort of be able to ask these questions is a whole nother challenge. So there's layers upon layers of challenges, if you will, to getting this data. That being said, the data is incredibly valuable, right? And so we need more research in this area. but historically this tends to be an understudied area.
As many are. Thank you for your transparency in answering that. When we're working with these couples that have IPV, can you speak some more to the frequency? Like, I think that's been my one of my takeaways at various conferences over the years, that I walk out of the room and I go, oh my gosh, like, how did I not know that XYZ was happening this often? Just so many different things. Can you speak about that? Because I think it's really easy when you see a couple on your couch that you're like, oh, they're invested in working on the relationship. That's why they're here. They're probably not engaging in any kind of IPV. But I'm guessing that's not necessarily true. So please correct it.
No, it's not. And I think you are absolutely right. I think if we sat back and we thought about the potential danger involved or what could go wrong, nobody would ever do couples work, right? The reality is, so I think we go in with a certain naivete, right? It's like, oh, they're here. They want to work on the relationship. And we all have a vision of what success looks like, right? We're going to turn this relationship around, and, we're therapists, we're optimists. Otherwise we wouldn't be in our business. Having said that, couples therapy is so complicated. We know that a large percentage of people that come to see us have been in some kind of violent relationship. In addition to that, couples come to couples therapy for various reasons, right? Ranging from, I really want things to get better, to, I've checked out of this relationship and I want you to tell us that we shouldn't be together anymore, right? So I think, like, it's having your eyes wide open. It's being my suggestion is being really thoughtful and deliberate about how you do your couples work. If we know that a large percentage of the people that come to see us have probably been involved in a violent relationship of some kind, assessing them is key. Assessing them separately is the key, on an ongoing manner, if nothing else. And when I say assessment, it doesn't have to be a long, dragged out assessment. It can be the best assessments are usually brief. They're brief, they're psychometrically valid, and they're feasible. So you separate before you see the partners. You have them fill it out. You look it over to make sure everything's okay. It also gives you a chance, if something isn't okay, if something happened, to talk about it. And when I say talk about it, do we want to discuss it in session? Does the partner feel safe? Does the partner need something more? Can I provide supports? But we can do that, right? So we're proactive, we're deliberate, we're planful. If we don't do that, that's when we run the risk of, it's sort of like going in there and keeping our fingers crossed that no one's going to say anything, that something bad is happening. So that's, I always think, if you're going to do couples work, have a plan. How are you going to do this? How are you going to account for the fact that so many couples have experienced violence, right? How will you measure it? What will you do about it? You don't have to have all the answers, but you have to have some of them, and you have to be ready.
In terms of counselors, therapists, social workers catching it, the importance of the assessment, separate, what are some of the primary risk factors that we need to keep in mind? So looking at substance use disorders, socioeconomic status, children in the home, speak to that. Like, what is the worst kind of pressure cooker to create IPV?
I think all of those things. What you just said was absolutely right. There's no one causal factor per se, but when you layer enough risk factors in, you've created the perfect storm for violence to occur. So the substance use piece, financial stress, marginalized group, family history, right? Increased stress level, precipitating event, all of these things, when taken together, can create this toxic stew that's more conducive to violence occurring. The challenge is asking the right questions to understand that, and I think we get some of the questions right and we miss a lot of the others. Think about alcohol, right? Like, as much as we celebrate it, you can't put the TV on without seeing something. It's just a part of our culture, right? And I guess many cultures, it's part of celebratory events, all these things. But we also know that there seems to be a link. Doesn't mean that everyone who drinks is violent, but it does seem that violence and alcohol are related. We see that with other drugs as well. Being aware of that is important. If we know these things, then we can help the perpetrator, and we can also help the partner to say, look, if this person's drinking or this person's using drugs and has a history of being violent, what can you do to make sure that you're going to be safe? Where can you go? Who can you call? What can you do with the kids? Again, it's that awareness piece so that we don't have our heads in the sand sort of hoping or fingers crossed that we don't find something out that's going to be potentially dangerous.
Let's pretend you had 100 couples in a room. Based on the research that you know, what percentage of them have experienced IPV in their past, and what percentage are probably actively engaged in IPV relationship in that moment?
In the past, I would say probably 40%. Yeah, and again, when we think about IPV, it's on that continuum, right? So there's that range of things that have happened. Active at the moment, maybe 10%, 12%. So again, we know that it's going on. We know it's there. The question for us as therapists is, well, what do we do about it? Another part of the issue, I think, at least from an agency standpoint, is we don't really have systems in place or infrastructure in place that is conducive to what we're talking about, right? Like whether it's policy or procedure, screening couples, automatically screening partners individually before couples therapy. I don't know that happens. Usually it's only one person. I don't know that, we talk about measurement-based care, but I'm not sure how many practices actually do that in an ongoing manner, right? And use the data to support treatment planning. So I think that's, the other issue is we don't often deliver treatment in the most efficient or effective manner. So that's the systems piece, the larger system piece beyond what's a therapist's responsibility and how should you make sure that you're doing the right thing if you're going to work with couples and families.
When I'm thinking about stressors that are contributing to that toxic stew, family stress is a very real thing, particularly if you layer on things like COVID that add just separation from community and fear of illness and potential medical issues. Like it's just, I remember reading probably in late 2020, just dramatic increase in intimate partner violence that was being reported. And that's just, whatever the field was finding out about, let alone what was happening that nobody knew about. So if we have this group of 100 couples and we'll say, hey, about 10% may be experiencing active IPV in this moment, not literally in this moment, but in their world, in their relationship, how do those numbers change when that couple is in the context of a family? And does that change based on the age of the children, for example? Like what are the factors that, again, make a couple higher risk relative to a family?
Yes, I think this is a super important question. Family stress is a factor, right? I mean, if you have kids in the home and parenting is stressful, right? There's often conflict about parenting approach. It also can lead to increased financial stress, right? Having kids. What you said about COVID was so telling because I remember at the time there were PSAs saying, oh, it's an opportunity to stay home with your family and play games and get to know one another. And it was like, that's the good, that's one end of it, right? But yeah. And there's a whole nother section where being at home, more family time isn't necessarily a good thing, right? And so I think that it can be a situation, especially where, like during COVID, for example, people's typical distractions were stripped away and they were gone, and and in many ways, their coping strategies, sort of like this existential crisis where it was like, whether it was kids or adults, we were all sort of left to wonder, well, what now? Right. And some people were able to reinvent themselves and figure it out. And I think for some people, it led to a lot of increased stress, anxiety, depression. Right. And I think that's the kind of stuff that when you heighten that, right, increased family stress, the stress of parenting, financial stress, maybe the relationship isn't healthy or happy. I think and then if you factor in substance use, that's where you get the toxic stew and the perfect storm that may lend itself to doing something that isn't very helpful.
I know from the research and my own lived experience as a parent of a child with disabilities, I remember walking out of the oncologist's office and going, well, that just increased my odds of divorce and marital unrest. are there studies supporting kind of these individual factors with kids? So it's like if you have a kid that has special medical needs, if you have a kid that is neurodivergent, for example, I mean, I've experienced that real time where it's like, yeah, that completely changes the stress within a family, the focus within a family. Has the research been finding the same of like these risk factors of like, oh, and by the way, if this thing is going on, that makes it this much more likely?
Yes. Yes, in some ways it puts it over the top. And I think in many situations, and I certainly will not speak for your situation, Beth, but I know like in other situations where you have this huge stressor that comes in, and if the relationship isn't grounded and solid, and in some ways what I mean by that is where partners can turn to one another to support one another. Let's say that there's already some friction there, and then you have this big stressor related to a child. What ends up happening oftentimes is people sort of turn away from each other rather than turning toward one another. And that turning away creates this distance, this emotional distance that then makes it even harder to get back together, to have that healthy dynamic. So I think that something that stressful, sure, if there's already some cracks in the foundation, can exacerbate it because, and I think it's trying to get back to a place where how can we support one another during this incredibly stressful time?
I remember, I think it was the Gottmans that had done research about effectively the different kinds of relationships. So when we're looking at really expressed emotion, so we have what I've classified in my mind, not using Gottman language, as kind of passive, assertive, active, and then danger zone. If we are not including the danger zone category of relationship in there, where there's so much contempt and personal attacks, things like that, we're looking at these other three kinds. Which of those three kinds tends to be more at risk for IPV? Is it because we all know that couple that's at like the dinner party and they're like seething, and then you look at the research and it's like, well, that doesn't necessarily mean that they're unhappy, quote unquote, or that their relationship is unstable. They just have high levels of expressed emotion. Are those couples more likely to have that situational IPV?
It's hard to predict, truthfully. I think it depends on the couple. What's interesting about couples is one of the things I learned early on, especially working with couples in which substance use was an issue, was when couples come in, they sort of each partner has an idea of what it is they're looking for. In more times than not, it's not perfection, right? So what I mean by that is, I'm a big scaling question person. I was trained as a solution-focused therapist. So when I say to partners on a scale of 1 to 10, with 1 being your relationship's the worst, it can't go any lower, and 10 being it's perfect, right? Sunshine, rainbows, unicorns, the whole 9 yards. Where are you on that scale? And, it's the first session, they say, well, we're 2 or 3. And when I follow up and I say, so in order for you to think that this was worthwhile, you got something out of it, where would you need to get on that same scale? They never say 10, right? It's usually like a 6, 7. Want things to get a little bit better, but overall it's fine. So it's sort of like, and that I say this because when I say the case by case basis, it's so hard to predict what people are looking for when they come in because you just don't know. Some people don't want it. They're not looking for perfection. They're just looking for it to get a little bit better. And I think understanding sort of each person's style and personality and how that fits, I think that's what makes it hard to predict, because you're right. There are those couples where it's like, oh, I don't know, why are they together and how do they stay together, right? And then you've got other couples that sort of look the part, where it's like, oh, they're so happy. And then there's all this other stuff going on. So you just never know.
Thank you. Thank you for explaining that. Before you and I started recording, you had talked a little bit about concerns with privacy, for example, related to engaging with someone through telehealth. This wasn't a conversation that people were having in 2010, but here we are in 2024 recording this, where so many people are seeking therapy online. I mean, I can already think about how complicated it would be to see a client individually. So you see them as a couple, you do telehealth, and then you say, okay, person A, I would like to meet with you at this time. I'll do an individual assessment. and you have no control over whether someone's standing at the door listening to what's being told to you. Can you speak a bit about the kind of ethical considerations here, not just with telehealth, but just in general when we're looking at working with IPV? And then the second part of that is like, what about the legal issues? You know, when you have a partner that beat the daylights out of another partner and the kids were home, like when do we decide what do you do in terms of intervention, understanding that this is relative to state law? But can you dive into that kind of ethical world and the legal world? Because that's another one of those places that's, I think, very tenuous.
Absolutely. I'll take the second part first. So I think in those situations where the partner beat the other partner up in front of the kids, I would never be doing couples therapy with that. But I would also, first and foremost, I'm always going to follow my ethical obligation. So as a mandated reporter, if I become aware of that, I'm going to let them know I'm a mandated reporter and I need to do something about this. I need to contact, in New York, it's Child Protective Services, right? Because I have a responsibility to do that. So I would be upfront. I'm always upfront and transparent about what are the limits of confidentiality, right? And when do I need to break confidentiality so that there's no secret as far as that piece goes. Clients may not always like, or couples may not always like my decision, but I have an ethical responsibility and obligation to do that when it's warranted. I spent, up until recently, I spent like 6 years working in pediatric primary care doing family therapy. And so you can imagine you get all kinds of kids coming in all kinds of situations, many of them in crisis. And there were oftentimes situations which exactly what you described, Beth, which was I became aware that a partner was violent towards the other partner and the kid was home, because the kid told me. And so it's a CPS call, it's always safety first and foremost. So for that piece of it.
Thank you for tackling the kind of legal part first. I'm realizing as you're talking about it that we just stumbled into another risk factor. Unfortunately, one of my experiences in my youth was having a friend who the person's parents were going through a divorce, and one of the parents got a restraining order against the other parent. And in response to that restraining order, there were some very significant things that unfolded with that family, and it was very significant in the community. I'll just say that. That is not unheard of. So can you speak about if we need to make that call, what do we do to scaffold the individuals who are at risk, knowing that if a police officer shows up and knocks on the door and says, okay, we received a report about abuse, come talk to me, that assuming that police officer isn't taking somebody with them, or if they do, that person's going to go back to the home, and this may be another pressure cooker for violence. What do we do clinically? What's appropriate to try to scaffold?
Yeah, this is, sadly, it's far more common than I would have ever imagined. And I'm thinking about a case now in which parents weren't together, but the dad was really violent, and even violent towards the child in public. And the child was 10 years old. And so, I let the mom know that I had to call child protection. I also talked to the mom about where she could go, who were some places that she could call, if she needed the support. We talked about restraining order. We talked about, there's something in New York, we have a family justice center that has all kinds of wraparounds and supports for people that are in family violence situations. So I made the referral for her there. When I contacted Child Protection, I also let them know, when I described what was going on, mom's situation, and making sure that if they decided to take the case, they understood the extent, severity of the violence, and also, any concerns or worries that mom had moving forward. So you're absolutely right. It's not just a phone call, right? Yeah. It's like, yeah, I can make a phone call, but that phone call is going to have implications for that child and that mom. And I also have a responsibility to make sure that they're going to be okay and that we can try to get them the services and supports that they need. It's not, I want to be clear, it's not a one-off. So I can give them that information, but then there's follow-up, right? Because I want to make sure I want to make sure they're really okay, other than being able to document, hey, I told them to do this or I gave them this information. So this is a continual conversation. I would probably also, like in this case, I asked the mom and the boy to come back a couple days later to make sure that they were okay. So I wanted to have more frequent touch points to make sure that they were okay. So does that make sense?
It does. And it's so complicated. Speaking as a clinician who at one point was living in California, Department of Child and Family Services, one region to the next, one city to the next, the services that are provided, how much a system is taxed. I mean, that's been a major issue in like the Los Angeles area, that there were just too many cases and not enough social workers, not enough caseworkers to manage them. And so even if our hearts are in the right places, if the infrastructure isn't there to provide the supports, I think it does become a lot more transferred to the clinician, because like, yeah, I'm not responsible for what the police department does or what DCFS does with this. They're going to do whatever they decide to do. But then how do I try to create an environment that is maximally safe relative to the context of situation? And it goes back to why, this is a really scary topic.
Well, it is, right? And I think your point is a good one. And then, I mean, we haven't even talked about how the court system works with families, right? And some of the decisions that get made there and the implications that it has for kids that are afraid to go and to visit with a parent, right? But the court, and again, speaking anecdotally, I've seen it a number of times. A child should, father should have a right to see his child, even though the father has done all these incredibly terrible things. And again, it's probably beyond that. This is a whole nother conversation in and of itself. But I think then there's that, right? Like, where even when people follow the right channels, do all the right things, sometimes the system fails them or they fall between the cracks. And it's like, hey, now I'm living my life in fear. Everybody told me I should do this. I should report it and I should go to the courts or the police, and now nobody's doing anything. So again, these are really serious matters. They're extreme cases, but they're serious and they happen. And I think we have to have our eyes wide open. I want to be super clear. I love doing couples work. I love working with families. I think that you can really make a difference. But this is a reality of working with families, right? Like I said earlier, we have to have our eyes wide open about what could potentially happen or what may be going on. If our goal is to help, right? I can't think of anything better than becoming aware of something like this that's going on and being able to help somebody work through it.
Thank you. I appreciate that. I want to make sure we go back to a conversation about like ethics. But one question I have for you that I haven't asked yet, what is the prevalence of family violence when there is existing intimate partner violence? And how often is there family violence in the absence of intimate partner violence?
That's an interesting question. I know that, it's interesting you say that there is intimate partner violence has an impact on kids' adjustment, right? And not just in terms of fear and anxiety and all these things, but it's almost kids begin to imitate what they see their parents doing, right? And if it's okay for a male to hit a female, well, then that's sort of what you grow up learning. So for some kids, and again, not all of them, but some kids, like, this becomes an acceptable behavior. Talking down to mom, disrespectfully to mom, right? Seeing a man do that, like speak that way to a woman, may increase the likelihood that this is what the child learns to do. And whether that's a teacher or whether that's a future partner, I mean, I think it speaks to the intergenerational transmission of a lot of these things. That's why when we look at a lot of these situations, right, when we sort of map them out and we see how it's not a one-off deal. There's this intergenerational transmission of patterns that is often unconscious, right? And even among people that live through it, they may say, oh, that was the worst time of my life, but then they turn around and repeat the same patterns, right? So I think that's where understanding that it's not just, the aggression from one partner towards another is awful, but what's the messaging that you're sending to your children? I think in terms of how do you relate to other people, but then also in terms of their adjustment, whether it's anxiety, increased anxiety, depression, and just their trauma response.
If roughly 40% of couples have a history of acts of violence in that relationship, if we take that and put it into families, how does that number change? Is there, like we talked about, risk factor, family stress? Does that mean that when you add kids to the equation, that the rates of IPV go up within a couple?
I haven't seen that statistic. And I think that the 40% is a lifetime statistic. So maybe it's in maybe it's in the current relationship, maybe it was in a previous relationship.
Thank you. Okay, thank you.
Yeah. So at some point, people are going to experience, we know what's going on. I think it still underscores the need to understand the dynamic between each partner and to screen. So, I don't think I touched on your question about telehealth earlier, and I just want to circle back to that if I can.
Absolutely.
Yeah. So I think that telehealth got out in front of all of us with COVID, and understandably so. It kind of had to. The genie's out of the bottle. But I think there were lots of things that we didn't consider. So when you're doing telehealth and you're doing it with a couple, right? How can you, like you mentioned, how can you ensure that if you're trying to assess somebody individually, that there's not somebody standing on just outside the view of the camera impacting what's going on? How do you know that the person is where, or the couple is where they say they are, right? How are you going to handle it if something does go wrong, if you become concerned, if you know there's a history of violence and then all of a sudden they start no-showing, right? So who can you call? Where are the local resources and supports wherever this person is? So I think it requires, doing couples therapy face-to-face requires a deliberate and intentional approach, but especially with telehealth. Telehealth is here to stay. And some people prefer it, right? But I think we have to be really aware of the limitations for us in terms of assessing safety and what that means and how can we protect our clients if we're going to do this.
Thank you for that, because it opens up a whole host of potential issues around safety, around privacy. Like you said, who's listening in, and that's a much less controlled environment than a waiting room and then coming into a clinician's office. Before we started recording, I had said, there's so much here. There's obviously only so much that we can cover in an hour because this is such a big, common, and complex issue. As we wind down our time together today, what are some of the most important takeaways that you want to leave with clinicians listening in? Particularly the clinicians that are working with couples and families, and this is just part of that water.
Yes. I think that the main points to me are it's really, really important to screen. If you're going to work with couples, make sure that you're screening them in terms of how they relate to one another if there's been violence. When you screen, always, always, always screen them separately. Don't screen them while they're sitting next to one another because their responses are going to be biased. So just be aware of that. And again, when we talk about screening, it can be real brief and simple. We used to use a response to conflict scale, which was 10 items, and it talked about behaviors that the individual engaged in, and then the individual would also report whether or not the partner engaged in that. It's a real simple one that takes less than a minute to complete. You can look it over real quick, glance it over. If there's anything you need to discuss, you got a chance to do that. If not, you go into the session, you're good to go. So screening is key. Okay. Violence is not one size fits all. This is the second point. So it ranges on a continuum. The vast majority of violence that we tend to see is that non-severe type that we talked about, the situational type, but there is that intimate terrorism type, which is really scary. In those cases, never, ever, ever do couples therapy. You can never, I will say this, you can never justify doing couples therapy in those situations. There's nothing you can say that would make that right. Heaven forbid something goes wrong and someone says, wait, you knew this and you thought it was a good idea. There's just nothing. So you never want to do that. The last point I'll make in this is that working with couples is incredibly rewarding. I'm a systems person, so I think looking at the system, people are part of larger systems and they engage in patterns. And oftentimes we just perpetually repeat unhealthy patterns, but we have a chance to help them learn new ways of doing things. And even in situations when, if there has been an isolated instance of a push or shove, we can help partners learn different ways of interacting with one another, different ways of relating, how to communicate effectively, rather than allowing it to get to a point where violence occurs. So those would be my main takeaways.
Thank you. I appreciate that. When considering those takeaways and the idea of working with a couple with a history of non-severe violence, what are the outcomes like? You mentioned outcomes, like, does it work? If we really work on communication strategies, if we work on self-soothing, if we do these things, is it working to reduce to reduce instances of violence, and also, I would hope, to increase relationship satisfaction?
Yes. So the data support that couples therapy in these situations is often more effective than just individual-based treatment. Again, intuitively, it makes sense. If you put two people in a room and you talk about how they can interact differently, then they're aware, each partner is aware of what the other one's trying to do and what their goals are, as opposed to working with just one person and then having that person go back into the system, right, or into the couple unit, and maybe be trying and the other person not understanding, or feel like the other person isn't trying. So the data support that couples therapy is an effective way to treat these situations. I always defer to what's in general, what's my client's preference? Again, recognizing the limitations, but if somebody says, hey, I really think it would be helpful to bring in my partner, sure. Right? If someone says, well, I don't feel like I'm ready for that, I don't want my partner to be involved yet, that's fine too. So, and again, that's sort of looking at the bigger picture in terms of outcome and tailoring the intervention to clients' needs and wishes.
Thank you. And I think it's valuable to restate that, because when I was in my master's program, what I learned, and I know many people did, was if there is any violence, if anybody has any hands on each other, you cannot work together in couples. And I think it's so valuable what you're saying, which is the importance of discernment, to classify and try to understand and then design a treatment plan based on that. Because, I remember that. It's been however many years, but I remember that if there's ever violence, you don't do it. And what you're saying is sometimes.
Yes, there's still a lot of people that believe that. This isn't always a popular viewpoint. But the data, if we believe in the science of it and the data, well, we know that it seems to work. So, and again, it's not me. I don't have an agenda in it other than I'll defer to my client. If the client thinks that this would be helpful, I'm certainly open to it. If a client says, I'm not ready to have my partner, and yet there's a lot of resentment, and I'm open to that too. So I think that's what, the client is the engine that drives the process. And then depending on the client's preferences, we've got all of these options, right, that we can consider. One of them being couples treatment. Fantastic.
This has been so helpful in organizing all of this information, especially when some of it is different than what we often believe. For our listeners who want to learn more about these topics, what are the best resources that they can look for?
National Institute of Health has a lot of really good information on partner violence, Center for Disease Control as well. Sandy Stith, as I mentioned earlier, STITH, has done a lot of work on couples therapy in situations where there's been violence. So her stuff is great. And she has a model that she uses that might be something that people would be interested in, at least sort of a jumping off point. So I'd recommend those resources.
Fantastic. Thank you. And for folks who want to learn more and about you and your work, what's the best way to do that?
So I am at the State University of New York at Fredonia. I am the program director of the Clinical Mental Health Counseling Program. I also work for the Cohen Veterans Network as a quality assurance manager. So you can always Google me. I'm on LinkedIn as well, but I'm not a big social media person other than that. So
fantastic. Again, for our listeners, this is Dr. Keith Klostermann. You have introduced so many concepts that are foundational to our support of couples, and even just, statistic that 40% of people have experienced some kind of couple violence, or, either perpetrated it or experienced it as an act of aggression against them. That's an astounding statistic that I don't think we're talking about.
Yeah, it's eye-opening,
Yeah.
Right? And I think it's not something that we often consider.
Thank you for putting these things more on our radar so that we can be more eyes wide open, as you say, in our work with couples, so that we're not missing these elements, particularly if we're not even knowing how to assess for them. How can we treat them? Thank you again for joining us, Keith. It's been a joy to have you and hear from you today.
It was my pleasure, Beth. Thank you for having me.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.